Cauchyrization of the duodenum.
So gallbladder and D1, those adhesions up to the CBD have to be released in all patients. But the proper cauchyrization up to the IVC only if you see any of these risk factors, you're anticipating a reach issue.
What is the laparoscopic ICU system you use? Because your images are very good. We've been using Stryker and the Rubina. Almost like half the time after injecting, there's no enhancement anywhere in the bowel or the colon. I mean, for LARs or even the gastric surgery. It doesn't seem to work. Your images are across the board there. The Indo-American images are anything different you did, sir?
We inject with a lot of love.
Did you ever face this problem?
Good. No. I think you need to understand the system.
That's all. So there are settings in the camera module.
Actually, when we bought 1688 in 2018, 17.
Yeah, 18.
It was probably the first system in the country then. The engineers in India did not know what the system was. Its potential, like me not knowing my phone. I only know incoming and outgoing, nothing else. So these boys, Nusrat, Srijan, Ajesh, who is in Apollo now, all these people worked so hard on the system, went on doing various things, and then they actually taught all the engineers in Stryker India. The ones in US who have made it may know lots of things. So it's like your BMW car, which you don't know. Many things you don't know. So you have to keep working on it. You should not compromise with suboptimal resolution or results.
I think 4 things are that you want to check in your system. One is what brightness you are working at, what enhancement setting you have kept. So for us, it's 4 brightness, 1 enhancement, 6 enhancement, 1 zoom. Other than that, the spy gain, if you are toggling through it. And the last is problem with scopes. I think we've gone through more than 1 scopes, and when you're having consistent problems in vision, I think it's the scope which is the problem.
Thank you. This ICG mapping, when you do it outside the body, how do you cut off the external light to get that vision? In lab, that's the only light inside.
Right.
So whenever I try, we cover with the sheet for a small pouch and all those things, but your images look like it's...
We switch off the whole OR lights.
That is enough?
Correct. For 2 hours, we have to go out and switch it off. So we make them go out and switch it off. We won't press record till all lights are off and all the BP is above 100 systolic.
Bala, you must learn to do things in darkness, even during daytime. So that is a trick.
Where to cut the esophagus? Because the reach problem is okay, but can we cut the esophagus little below? At the same time, should not have a vascularity of upper end esophagus. Is there any cutoff or 3 centimeter or just below the clavicle or just above the clavicle, anything?
Or we end up converting into an Ivor Lewis.
So I think where the primary tumor is, I think a margin of proximal margin is fine.
Never issue for this.
No. By the time you understood the stomach is not reaching, it's beyond Ivor Lewis. You have already cut the esophagus, is it not? You are beyond Ivor Lewis. You are committed to neck anastomosis, married to neck anastomosis. So yeah, but you have to anastomose.
Little safe, can we cut little below? But that the same.
You can do that if the margin permits.
But I mean, one problem is
not middle third. If it's not middle third, you can do that.
Yes.
No, in the neck, if you do it, one problem I had faced, I think I discussed that with sir also. If you leave the esophagus too long, the leak when it occurs, it seeps into the mediastinum also. Yeah. Exactly.
Correct.